So good morning, everybody. So it's always pleasure to back in Hyderabad. Like that's a place where I had done my master's, like bachelor's, master's, and worked initially for 3 years at Hyderabad. And my interest in voice disorders actually developed when I started working at Hyderabad with a phonosurgeon. So I was working with Dr. Fanindra Kumar in his clinic. So I used to see a lot of variety of patients who are like singers, teachers, bank employees, and several other category of even the singers who used to go for competitions like Indian Idol. These kind of singers, they used to come over there, and I'm like a typical from the institutes like AYJSRC, KELLER'S, like where we don't have very much caseload. We have seen around, I have seen around 3 to 4 patients during my bachelor's and master's. I think bachelor's maybe 3-4 patients, master's maybe another 3-4 patients. So with that kind of background, when I had to work with the singers and this kind of population, I was very much tense initially. So I wasn't understanding, and I had several questions, in fact, rather than solutions to them. So some of my questions I put forth over here. And another thing is, as I worked at Aish for 10 years, so I was teaching voice paper to bachelor's and master's students over there. So when the students go out of Aish, they often call back to me asking like, sir, we have a patient, how do we go about it? So usually the questions are like, am I using a right voice therapy approach? So that's the first thing, when you have a patient with you, you do not know whether you're using the right thing or not, because the patient, you may be in a private clinic, the patient is paying for therapy, or you're at an institute where you are given with a patient, you are in second year bachelor's or third year bachelor's or master's. That could be your first patient you're working in voice disorders. So there will be several questions that I put forth here. And to tell you all the audience over here, I do not want this presentation to be a formal presentation where it's like a seminar where everybody is talking about the topics and mostly theoretical. So I want to keep it mostly practical oriented. I want people to get an idea, like when a patient comes to you with voice disorder, what is that you can work with, right? So, and it's actually looking very odd that I don't have participants looking at me, or I often presented in front of the audience, but we are living in this COVID world, and then that actually gave us new avenues, like you can speak globally, all right? So to keep it simple, I have put for some questions, and by the end of this presentation, I hope you would be able to answer these questions to yourself, and you'll get an idea about how to handle a patient when he comes to you with voice disorder. And another thing, I'm not focusing much on diagnostics, like either stroboscopy or any acoustic analysis, something. This presentation will be mostly on the voice therapy approaches. Okay, so students often ask me these questions, like I had demonstrated voice therapy approach in the first session. So they feel like I'm done, like I gave him relaxation exercises or Yansai approach, or whatever you say, digital manipulation. So I did it in the first session. What do we do in the second session? So they feel like they had to go for a second approach or third approach, right? So it's always a question like, what do I do in the subsequent sessions? And then what exactly do I do in a 30-minute session? Like often we do, like we give them a list of vocal therapy, vocal hygiene tips. Okay, these are the things you have to follow: drink more water, don't eat spicy foods, don't go for Hyderabadi biryani, right? So any patient with voice problem, biryani is cut for him, right? So that's what we do in the initial session. Okay, first session that is done, your vocal hygiene education is over. You gave them a list of vocal hygiene tips. You probably worked with a voice therapy approach, but then what next in the subsequent sessions, like how do you go for the 30 minutes of your session? What exactly you can do? So that's another question that's been frequently asked. And should I ask my patient to stop taking spicy foods and drink lots of water? People take it by default, a thumb rule, like if you have voice problem, keep a bottle of water next to you and keep on sipping. I think I often feel like keep doing this, right? So I'll talk about these things, like whether you have to stop spicy foods for everybody, or how much water to drink. Do they have to drink lots of water? Everybody has to drink lots of water. And what approach to use with a particular voice disorder, hyperfunctional voice disorders, vocal fold paralysis, singer's voice, puberty. Sometimes people say it is simple speech pathology, is nothing, like just producing some sounds and sentences, like special education work. But if you see deeply into it, like voice disorders itself is so vast, from singer's voice to puberphonia, pediatric voice disorders, geriatric voice disorders, neurogenic voice disorders, psychogenic voice disorders. So it's again within itself is a lot of it, right? So you work with puberphonia. When a patient with essential voice tremor comes, you do not know how to go about it, right? So in this particular presentation, I'll be telling you general principles which you can use across the voice disorders. So we'll try to speak about some rationales about voice disorder, the voice therapy, and when to use what, right? And another question that's frequently put forth is, again, my patient is a singer and I am only having issues with singing voice. When you see especially singers, their speaking voice is normal. Only they have issue with singing voice, and that too, trust me, when they sing in front of you, you feel like they're doing awesome. Like, why do they come to you, right? That's just because you cannot sing, or I cannot sing as an SLP, right? So you need not be a singer to work with singing voice. So we will talk about some of these things as well, right? So anyway, so I just looked into, introspected myself, and I listed out what questions I had when I was a student or when I was an early clinician working outside. So you can definitely come up with some more questions at the end of the talk, and we will discuss about them. Okay. Right. So this is just a simple overview of what I'm going to talk about. I'll speak about how the voice therapy works. We will take some, we'll talk about some rationales and application of indirect voice therapy approaches and direct voice therapy approaches. I'll try to demonstrate. I kept my daughter next to me. So whenever it's time for demonstration, I asked her to be a model for today. So she'll be here. I'll be demonstrating some of the therapy approaches on her. And I'll also talk about how to plan for a voice therapy session. Like, as I told initially, like what exactly you can do in a given session of 30 minutes and how to go about across the sessions, as a progress in the sessions, how to track progress. Like you have to see whether the patient is progressing or not. So we're going to talk about all these things in this presentation, okay? And before I go further, I want to tell you, like, after being in USA for 3 years, I don't know whether my accent is, it's neither American nor Indian. I ended up in between because every day we struggle to suit the American accent, because I work in a school where there's a lot of IEPs. I need to talk to parents. So I try my best to suit their accent. But when it comes over here, I need to, talk back in Indian accent. So I'm sure it will be weird accent in between. So please bear with me. Even I used to comment when an American, like, Indian Americans, when they speak, so why are they faking their accent? But trust me, it's not actually faking. When you're into the topic, it automatically comes up. When I stayed in Telangana for 10 years, I used to speak in Telangana accent. So people used to laugh at me when I go back to Andhra, right? So it's a natural thing, I believe. All right. So going back to the topic here, how does the voice therapy work? So I put up some general principles like how voice therapy works. Like when you treat the precipitating factors that improve the vocal output. So I put up some general principles, not from the textbook, based on my experience and based on what I studied from different books. So first thing, we'll talk about treating the precipitating factors. So this is where I would like to talk about the using a sheet with vocal hygiene tips versus the typical vocal hygiene education, right? So when you treat the underlying conditions, when you educate the patient about what the normal vocal folds are, how do they look like, and how their vocal folds are, right? So that itself would give them a lot of clarity on what exactly is happening with their voice. I'm sure you would have seen several times in your day-to-day clinics. Most of the patient doesn't know what's happening with them. Like if you ask them, do you know why your child is not speaking? They do not know. Like, I don't know why my child is not speaking. They're in the speech therapy for 1 year. Still, they're not clear why this particular child is not speaking. And whereas the other children are speaking normally in their own home, right? Similarly, when a person with voice disorder, when they come to you and you straight away start with some vocal exercises like relaxation or breathing exercises, they do not know why they have a voice problem in first case, right? And I'm sure most of you agree, you do your best when you know why you're doing something, right? Like in my school, I never used to study history because I used to think the king died long ago. Why should I read about him? Why should I write an essay about him? I used to always avoid it. But now if you see me, I'm on YouTube all the time looking at Second World War, First World War, Indian history, American history, because it is said in a better way, right? So similar thing, like, and I know how important the history is now than when I was in school. So similarly, if you tell your patient why the voice problem has occurred and what's exactly is going wrong with him, so if you make him aware, if you educate the patient, half of your problem is done. Because now you are not responsible, like more than you, the patient is responsible to take care of his voice because he knows there is a nodule on the vocal fold. He knows there are two vocal folds and there's a nodule on one of them. And the nodule has to go away for his voice to improve. Otherwise, you're taking the whole onus on you, saying that, okay, you have to come for 10 sessions for the voice to improve. And the patient will ask you after 5 sessions, okay, no, my voice is not improving. So let me drop the sessions, right? So educate the patient so that they can take the responsibility of their voice problem, right? So typically what I used to do, even as part of my thesis was efficacy of eclectic voice therapy program in patients with hyperfunctional voice disorders. So hyperfunctional voice disorders is also called as muscle tension dysphonia. So I was looking at the efficacy of an eclectic voice therapy program in these individuals with muscle tension dysphonia. So as part of my thesis as well, I developed a protocol like how to go about with voice therapy sessions. I used to see for the patients for 12 sessions, like that is, you don't know whether the 12 sessions would be enough or not, but that is my protocol for my thesis. So I used it to work on the first 2 sessions on vocal hygiene education, just educating the patient. So my task was to play a normal laryngoscopy video. So I used to have always a normal laryngoscopic video ready. I had recorded actually my own video laryngoscopy while I was phonating. So I used to show them, this is how the normal vocal fold looks like, and they vibrate to produce the voice. So because the general public doesn't know how the vocal fold even looks like. So I used to tell them, like, the vocal fold come close and the pressure builds up and the vocal fold go apart and produce a sound. So that sound is generated there and amplified in the oral cavity. So this is how the normal voice is produced. But in your case, the vocal folds are not closing completely because there is a mass in between. Suppose a vocal nodule. So this is obstructing your vocal folds, right? So when there is an obstruction, obviously the closure is not happening. So there will be leakage of air, right? The air is leaking out. That's why your voice is breathy. So instead of sounding like, now the patient is sounding like, that's because there's a gap over there. Now the patient will, yes, sir, I can understand. Well, there's a gap over there. The air is leaking out. So I have to close the vocal folds to reduce the air leakage. It's as simple as that. Now the person understands what he has to do. I mean, what has to happen with therapy. So I used to tell them, okay, once these nodules are out of these vocal folds, your therapy is done, right? So now you gave them an evidence base to see that when the therapy, they'll be out of therapy, right? I just had a small clip here. Anyway, that's just only to show the vocal folds and how the vibration happens. Right. So then I used to play their video because we had a team like ENT, even obviously, even you guys, when you're working outside, always see a patient only after it is he or she is seen by an ENT surgeon, because you don't want to assume that the hoarseness of voice is because of vocal nodule or a polyp. It could be even carcinoma. You might be wasting the patient's time, valuable time. So always see the patient only after ENT surgeon's referral, and or work with an ENT surgeon as a team. So that's what I used to work with a phonosurgeon. So we used to stand together there and see the laryngoscopic video. We used to discuss and come to an agreement. It's not a competition, it's a teamwork, right? Even at Aish, we used to have the same system. In the ENT used to come to the voice clinic. I used to go to voice clinic. So we together see the patient, discuss about what should be done, whether the patient needs a medical treatment or voice treatment, or it could be combination. Okay, let's work for 10 sessions and see how the patient is improving. Then if the patient is not improving, probably then we can go for a surgical treatment kind of. Okay, so my point is, you will have a laryngoscopic video. If not, ask the ENT to send you a laryngoscopic video of the patient. And normal videos you can get online. On YouTube, you will get normal laryngoscopic videos. So play both of them and show the patient how they're different. Okay, discuss the differences and pinpoint the cause and consequences of the voice disorder. So why most probably the voice disorders occurred. So it could be your unhealthy vocal hygiene practices, like talking against the competing noise. So mostly in schools, like children are also talking. So children are talking, the teacher is talking. So when everybody is talking, there is a lot of noise in the classroom. So the teacher has to raise the voice to speak against that background noise. So if that is the case, try to identify that. So try to identify all those behaviors that could have contributed to the voice problem, right? It could be throat clearing. Throat clearing is also actually a symptom, but it could be excessive throat clearing, a lifestyle related problems such as somebody working in a BPO till late night and they're having late dinners or eat at 2 o'clock in the night and then sleep immediately. The secretions could be washing away the vocal folds. So that leads to redness in the vocal fold and eventually like laryngeal pathologies like laryngeal polyps, this kind of. So that could be the condition. They might not be drinking adequate amount of water. They could be diabetic, where they pass a lot of urine and dehydration happens. So that also could be a possible contributing factor that need not be cause, but could be a contributing factor. Sometimes people come to you after delivery, delivering a baby. So they had a surgery. So that could be a singer who used to sing very well before, but after pregnancy, due to hormonal changes and the surgery, that that they have undergone, like C-section. They could be having respiratory, lack of reduced respiratory support. So that could be a contributing factor. But with that reduced respiratory support, they're still singing, right? When they sing with less support, that's when the tension develops in the laryngeal system. You need the lungs are like your reservoir. When you have good respiratory support, that's when your voice can produce a best voice, the optimum voice, right? So that could be the problem. They have reduced, breath support. So try to identify and pinpoint what are the unhealthy practices they're having, so that you can, instead of giving a vocal hygiene tips, which is a list of them, and just ask them to follow. Like, as I gave example before, the person doesn't have GERD, gastroesophageal reflux disorder, or if the patient is eating at 8 o'clock and sleeping by 10 o'clock, they have adequate time in between. Please do not ask them to stop spicy foods. I have seen people giving up for lifetime because the voice therapist has told them, right? So your decisions or suggestions has to be based, evidence based. If the laryngoscopy is showing there is redness on the vocal folds in the posterior side, from the esophagus, the acidic contents are coming onto the vocal folds, only then you suggest them not to go for spicy foods. And if the person is already drinking adequate amount of water, please do not ask them to keep on drinking. I have seen people, as I mentioned, they'll be more time in the bathroom than in their office. So you have to see what is contributing. So pinpoint the problems, then suggest the tailored vocal hygiene education for them, because vocal hygiene education is a science. It's not a list of tips, right? And so what exactly you can suggest? Typically vocal hydration, we already talked about it. Hydration is important because it creates lubrication. Imagine the door is making sound, like creaking sound, because there is rust on it. So what do? You go with some lubricant. You put some grease, oil, so it becomes smoothened, right? So similar way, when the vocal folds are like dry, they do not produce the optimum voice. Or when the secretions are there in the vocal folds, like when you have postnasal drip and there are thick secretion sitting on the vocal folds, that's when the person try to clear the throat, because the mucus is sitting on the vocal fold now. So the vocal folds are very sensitive. So now they have some weight on them. Now the person is trying to clear the throat, like so that the mucus jumps out of the vocal fold. But then after a while, again, the mucus come and sit over there. Because the secretions has become thick. The room could be dry, less humidity in the room. So any of these reasons could make the secretions thick, and the person is clearing his throat constantly, right? So that's what the water helps in thinning those secretions, so that the person need not clear the throat, take water instead. And the lubrication develops, and the person will feel better in his voice. Now, I used to have this question, if not me, the patient will have the question, sir, I'm drinking water, it's going to my stomach. How would my larynx benefit from that? Even I used to think, because, you should not drink water into the larynx, right? The water should not enter. It leads to aspiration. And the person could die of aspiration pneumonia, all this, right? But then the water is going into the esophagus. How does it help the person? So to answer this, there's several articles published on this. There's a lot of research done in this area. There's two kinds of hydration. We call it systemic hydration and surface hydration. Systemic hydration is the person is drinking water. So the water goes into all the parts of the body, every part of the body where you have mucous membrane, like the salivary glands and eyes and the tongue, vocal folds, wherever you have mucous membrane, the secretions increases, the mucosal, the saliva increases, the salivary secretions increases, the mucus becomes thinned, and that's how it's benefit the person. So drinking the water, it's going into the body, into the stomach, getting digested, and going across all the parts of the body, including the vocal folds, right? So the other kind of hydration here is surface hydration, where literally you are spraying onto the vocal folds. Now, how do you spray onto the vocal folds? You cannot spray water onto them. So steam inhalation. There have been several studies documented that steam inhalation benefits persons with voice disorder, right? They need not put anything into that, no turmeric, no Vicks, anything, just plain water. Just take steam inhalation. The steam, because of the vapors enters the laryngeal system, the mucus get thinned down again, so that the secretions go down the esophagus. So the person need not clear his throat again. Okay. So I typically recommend all my patients to go with surface hydration, because I tell them to do steam inhalation at least 2 times a day till the time they are in voice therapy, because mostly this is seen. But again, you can look at the laryngoscopy and you can see when there is thick mucosal secretions, the vocal fold move like this. You can see there is a string of mucus between the vocal folds, right? When there's a string seen, that shows the mucus, the thick mucus is sitting on the vocal fold, and you can see literally a white mucus sitting on the vocal folds, right? So that's when you can suggest for just systemic and surface hydrations. And systemic hydration, ask them to drink when they are thirsty, right? But surface hydration, you can ask them to do 2 times a day steam inhalation, just for 5 minutes. That should be enough. There are several studies that has tried to see the dosage, how much water, how much steam inhalation, all these things. But then you can suggest that 2 times. That's what most research has indicated. And vocal naps. So vocal naps are like, how you take a nap when you're tired. The vocal folds also gets tired, so they need a gap to recover, right? So mostly the vocal nodules, all these occur because the person is not giving adequate time, the recovery time. Suppose, imagine a teacher, he teaches from morning to evening, goes home, and next day morning again same thing, next day morning again same thing. Even at home, they have to teach their kids, shout at someone else, right? So it's never ending. So that also leads to the voice issues. So give them, recommend the vocal naps. So you can have a schedule, you can voice dosage and schedule them. You can plan, sit with the teacher, suppose it's a teacher, sit with them and help them plan their sessions, like, the classes. Instead of taking continuous 3-4 classes and then a gap in the afternoon. So you can suggest them to, take adequate gaps in between, like, one class and a gap, another class and a gap, so they can make a schedule and work appropriately. Having appropriate posture, because, most of you already know that, the abdominal pattern, abdomen thoracic pattern is the optimal posture for breathing, because the lungs has to expand to their optimum level. So when the lungs expand, you can take more air, and the vocal economy would be better with that, right? And also, if the singer that comes to you, suggest them vocal warm-ups. I'll try to demonstrate what the vocal warm-ups are. So try to suggest for vocal warm-ups, because imagine, you are into sports, like you watch cricket, some of you may be into martial arts. So what do you do as soon as you go to the ground or your martial arts practice? So do you straight away do your martial arts, or start with your cricket practice, or do you do running, right? Running or some exercises, stretching. So the muscles need warm up. So when you do warm ups, the temperature in the muscle increases, the blood supply increases, and it makes the muscle ready for the strenuous activity. So when you say strenuous activity in the voice, in terms of voice, you're talking about taking a class or going for a concert. Like a singer has to sing for an hour, then let them do some vocal warm-ups before that. so that the vocal folds are ready for singing. So there is good amount of, the temperature over there, the blood supply, oxygen levels. So everything is like, that the body knows, okay, this is at its best. So that's when they can do the strenuous activity, either class or singing. So that's how the vocal warm-ups benefit. So if it is a singer, definitely it's suggested that they go for vocal warm-ups. Even the non-singers can go with this. All right. So that's about the vocal hygiene education. So educate the parent, educate the patient, let them take the responsibility, let them see their vocal folds. And I also used to do, like, after 8 sessions, I would go to the ENT. I know many of you will not be having this privilege of going to an ENT again. But if it's possible, send the patient to the ENT back and ask them to see how it is improving. Okay. Or if you're working in the ENT setup itself, then go to the doctor and tell them, okay, I have worked for 8 sessions. Now I want to see how the vocal nodule is responding, or polyp is responding, the vocal fold paralysis, whether the closure is taking place, or the affected vocal fold is moving, some movement came in the vocal fold or not. So do a mid-therapy evaluation to see how it is improving. Again, that motivates the patient a lot. And trust me, these are the things that might sound simple, but your quality of therapy would shoot up. Your patient will be satisfied because he is seeing every day what's happening, right? And one more thing I'll tell you, like towards the end of the presentation, about tracking, so that you are giving again another responsibility for the patient to see how to track his own progress. We will talk about that in the next slides. Okay, so but that's about your treating the precipitating factors, let it be acidity related issues or any vocal unhygienic vocal practices. So if you treat all these things, the voice will improve automatically to some extent. Okay. And the second principle for voice therapy, based on which the voice therapy works, is developing a balanced system. A balanced system would generate better voice. I think the better example when you speak about balance would be to talk about stuttering, right? What happens when a person, the voice hasn't started, the voicing hasn't started, but the articulator is super excited. He wants to say any word like money, right? He wants to say money, like you go like, he does this because the voicing hasn't started, the voice is not coming up, but the articulator has started, right? So what is the therapy technique used there? Do some humming, not humming like, money. When you do that, you're actually activating the laryngeal system, right? So the articulator is waiting for it now. The voicing is started before the articulator. So instead of saying like, instead of moving the articulator, now he says like money, right? So that's how the coordination is important. And I want to tell you this, the voice, mostly I would have started with this actually, my presentation. The voice is not just produced by the vocal folds, right? Most of you are aware. Each system has its contribution to it. The respiratory system, phonatory system, that is larynx, the muscles around the larynx, the resonance, and the articulation. Everything has a contribution to the voice production, right? And the voice will be generated at its best only when there's a balance across these systems, right? So there's one approach that's developed based on this premise that the voice, the subsystems of voice production requires coordination, right? So Stemple calls these as subsystems of voice production, right? So what are the subsystems of voice production? Respiration, phonation, and resonance, right? So it's not just the larynx, it is all the subsystems of voice production has to work in coordination. So strengthen and increase the coordination of the muscles of voice production. So how do we do this? Stemple says 3 steps for vocal function exercises. So these vocal function exercises are also based on the exercise principles. Like imagine a person with vocal fold paralysis. It is typical, even I used to do that, to go for pushing pulling exercises, which is totally contraindicated. You should not do pushing pulling exercise for vocal fold paralysis, basically because you don't know how much you're pushing, right? And you're actually when you push, and there are some studies that have seen while you push, and then they have seen through the nasolaryngoscopy, it is not the vocal fold that is coming into contact. It's the supraglottic structures like ventricular folds are coming into picture. So you are actually inducing ventricular phonation, not developing vocal fold movement, right? So by pushing, you're not helping the vocal fold move better, but you're inducing the vocal hyperfunction, right? So taking that example of vocal fold paralysis, so do not go for those symptomatic approaches like pushing, pulling something, but instead you can use these vocal function exercises given by Dr. Stemple. So this is based on the exercise principle. Suppose what is happening in vocal fold paralysis, the muscle tone has reduced because the vagus nerve is paralyzed for a long time. Suppose say the patient is coming to you after a month of vocal fold paralysis, or 2 months, 6 months. So all these while the muscle is not getting any input from the nerve. So now I'm sure you are aware what will happen to muscle when there is no nerve input. You have seen children with polio, like, it's not there nowadays, we have vaccine, but I used to see several kids with polio, and you might have seen some adults with polio. How does their leg look like? It is thin, right? Thin leg. They'll have good biceps, but the legs looks thin. And you might have seen somebody with paralysis, paralytic stroke, like the hand is paralyzed. So after a while, after a few months, you will see the hand doesn't look like this. The hand will be like this. It is shrinking. Why is it shrinking? Because there is no nervous input, right? The nerves are not working over there. There's no neural input to it. It's like your electric supply. So its supply is stopped. So same thing happens to your vocal fold as well. The muscle shrinks because the vagus nerve is paralyzed. The vocal fold is now shrunken. So that's why one vocal fold looks intact. The other vocal fold look like this, right? It is now shrunk, right? So that's what we call as loss of muscle tone, bowing of vocal folds. You will also see this in presbyphonia, like people with geriatric voice disorder, like when they're aged, so their voice becomes, the muscle tone reduces. As you see there, the bicep muscles, the cheek muscles, everything gets flabby. The vocal folds also becomes a little flabby. The muscle tone reduces. So now how to work on these individuals like vocal fold paralysis and presbyphonia, like geriatric voice. So how do we go about it? So if you're using vocal function exercises, the first step in the vocal function exercise is to stretch the vocal folds. So how do we stretch the vocal fold? You cannot do it like this, right? So if you go back to your anatomy, sternocleidomastoid, why I'm saying that? Cricothyroid muscle. So CT Weiser mechanism you would have heard about. So cricothyroid muscle is the muscle that helps in increasing the pitch, right? So the cricothyroid muscle has to stretch so that the voice, the high pitch can be produced. So now when you say stretching the vocal folds, so the first step here is to produce, the first step here is the vocal warm-up, as I already spoke about. First you have to warm up before stretching. So the first step in the simple exercise is vocal warm-up. So just produce, like you can use either humming or production of E or O, something like this, like E, as long as possible. That's why it's called as maximum phonation task. Or you can take it as because it's also, I'll tell you, this also benefits when you do humming. So you can go like I recommend you do along with me. because I'll be demonstrating some of these approaches. You do along with me, that would benefit. And you can be a best clinician only when you practice on yourself. I did stroboscopy on myself. I practice every approach on myself before I use on my patient, right? You have to use it several times on yourself so that you can experience what exactly is happening, right? It's only when you experience, you can tell your patient, how do they experience, right? So vocal function exercises. Meghna, want to come here? So I'll stop sharing my screen here. I try to, where do I screen my screen? Yeah, she is my daughter Meghna. So I asked her to volunteer to be our subject for today, the model for today, right? So the first step I told you is the production of a constant pitch. Like you're not gliding, you're not stretching, you're not contracting. It's just a modal pitch. When you say modal pitch, it is your regular day-to-day using. So the first step would be just phonate, just flat pitch. Right, and do it 2 more times. Sit straight, sit straight. Keep your head at the neutral position. Take comfortably deep breath and go like good job. So this would be the first step in vocal function exercises, but sometimes you might feel like the person is not able to produce this much voice. So I'll tell you what to do for that. But we'll go to the second step in it, that is stretching exercise. Now, when you say stretching exercise, you're actually working on the cricothyroid muscle. So you're stretching the vocal fold so that the muscle tone can improve on it. So now you produce with a glide, okay, like a siren. So it's very important to use these words because the patient will be initially smiling at you, laughing at you when you say siren, or when you do something like this. So people will laugh because they're not very familiar with this, right? So you use different words to explain it and tell them it is very normal to do it, and tell them the words, use the words as siren, a glide, or if they have some singing background, say arohana, avarohana, these kind of words, so that they can understand. And you can also use like hand gestures, like right? So Meghna, can you do that? Do it 2 more times. So you're actually stretching the vocal folds gently, and so please make sure that the posture is correct. Like, the person is sitting with the back straight and taking comfortably deep breath, not excessive tension in the laryngeal muscles, and the face is neutral. It's not elevated, because when you ask them to say glide, they will go like and so they tend to move the neck. So we are only looking at cricothyroid muscle, not the neck muscles, right? So let's stick to the cricothyroid muscle. Now you do the other step, that is contracting the vocal folds. Like when you say contraction, it is thyroid muscle, right? That's a contractor, right? That relaxes the laryngeal vocal folds and produces a low pitch voice, right? So now you go from middle to low. I'll demonstrate. Very good. Just stick to your comfortable range, okay? Let's do it 2 more times. Right, 1 more time. Okay, right. So this is what we call as the contracting exercise. So we did a flat pitch, that is to warm up the voice, and then stretching exercises to work on the cricothyroid muscle, and contracting exercise to work on thyroid retinoid muscle. and then produce a different pitches, produce same humming or E at different pitches. So now say this. Little high pitch. Little more higher now. Right. So now we are producing the, we're not gliding now, but we are producing at different pitches. You're stretching at different pitches, right? So these are called as strengthening exercises or muscle strength exercises. That's what the Stemple says. So go through these 4 steps. Let me share my screen. Back here, right. So thank you, Meghna. I'll call you back. Right. So that's what we spoke about, the vocal warm-up, stretching and contract. You can be here. Sit here. Right. Stretching, contraction. So this is what actually improves the muscle tone in the vocal folds. So if you have a person with geriatric voice disorder like presbyphonia, so their muscle tone can be improved with this. You can work on vocal fold paralysis, or even those with hyperfunctional or hypofunctional, both kind of voice disorders, right? And the last one we spoke about, prolonged phonation exercise, or we also call it as muscle strength exercise, strengthening exercise. So this is useful for modifying the tone of voice and promoting respiratory drive to sustain the phonation. So at this step, we're actually trying to take a comfortable deep breath. Like you're working on all 3 systems simultaneously. Take a breath, phonate at a comfortable pitch, and then at a given pitch, and then go as long as possible. So you're working on your resonance, the tone, focusing the tone, respiration, as well as the laryngeal system, right? So that's about the vocal function exercises. And the next one, the next principle about voice, how the voice therapy works is the natural resonance can yield better vocal economy, right? So you might have heard about resonance, when the pendulum moves, when the 2 bodies have same frequency, the natural frequency matches with that, the amplitude of the pendulum increases, right? So same thing happens with your vocal fold. Imagine you have a mobile phone with a small speaker. I mean, it produces less sound. Now, if you have to amplify the sound, put it on a mug or put it on a pot, the sound will be amplified, right? Now, imagine your vocal folds as a mobile phone and your vocal tract as the resonating chamber, either your mug or pot. I'm using the general colloquial, informal words because this is how you can explain your patient as well, right? So this is now how you put your mobile phone on the mug. Similar way, you imagine your vocal folds sitting on the vocal tract, right? Your oral cavity, mouth, nose, and the pharynx, the tube over here. Excuse me, the tube over here. So when you can create the resonance, so the vocal fold that generated voice here is very feeble. It will not be heard, right? But if you can create a natural resonance to happen, that's when you will have economical voice. When you say vocal economy, you can speak for longer duration, louder, with minimum effort, right? That's what is needed for the singers and teachers, right? They need more vocal economy, something like your bike giving good mileage. So the voice has to give good mileage so that the person can speak for longer duration without having much effort. So which will not lead to any voice disorders like vocal nodules or all those, right? So we need natural resonance to take place. But mostly when the patient comes to you, they will come with most voice disorder patients. When they come to you, they come with a back focus voice. When I say back focus voice, the focus is at the laryngeal level because they know the voice is coming from here. So tend to tense the larynx and produce the voice like, the larynx is pulled down, right? Pulled down, or sometimes it's pulled up. Like when you see pubophonia, It's also kind of muscle tension dysphonia where the larynx is pulled upward. So the larynx is not at a stable position. It's pulled up or down, and they're creating a backward focus and not using the resonance optimally, right? So how do you facilitate resonance? There have been several approaches that came in this area. Luckily, I used to use resonant voice therapy kind of thing when I was in Hyderabad, like without even knowing what is RVT. I used to work on Brahmari Pranayama with my clients. I used to work on Brahmari Pranayama. So I used to use the fingers to feel the vibration sensations, and I used to make them produce like humming sound. So basically, your goal in resonant voice therapy is to create optimum resonance. The person has to have a throw in their voice. And I'll share some experience in this with this. I had a patient who was a government employee who had voice problem, who is also a singer, very educated lady. So when she came to me, I was explaining about resonant voice therapy, how to produce a forward focused voice, because that's what book says, forward focus, backward focus versus forward focus. I've been working, the patient didn't understand. I asked her to use the fingers to feel. And one more thing I do is bend forward parallel to your thighs, so that the gravitational pull will make you feel the vibrations in the forward, the nasal cavity, facial bones, everything. So that's another thing that I used to use. It has to be tailored. That's what my point is. Each patient will be different, their educational level and their understanding. So with this patient, what I'm speaking about, she did not understand forward focus. She did not understand that throw in the voice. She did not understand release of voice. So I used to explain, forward focus versus backward focus. You're using a backward focus, try to make it forward focus. Because there's nothing we are not using any instrument to show their resonant voice, right? Unfortunately, there is not much instruments to show them, give a biofeedback of how the resonance is happening, a forward focus versus backward focus. We were working on developing some instruments to show the resonance. It wasn't successful yet. So what you have to use is imagery. The person has to imagine a forward focus versus backward focus. So when you want the person to imagine, you have to make him understand, right, what to imagine. So I was using forward focus, throw, release voice, holding versus releasing the voice, holding versus throwing the voice. She didn't understand with anything. I worked for 2 sessions, 3 sessions. She wasn't improving. I was wondering why she's not understanding it. She was an educated lady. Then she's asked me one day, "Sir, you want me to produce an open voice?" I said, "Yes, it's an open voice." Immediately, she started producing a resonant voice, right? So it is how you're explaining the patient. What you are imagining, the patient should imagine the same, right? So that's why you can use these words to demonstrate, explain them what is expected. You can use biofeedback. The fingertips is a part of biofeedback. Or, you can sometimes ask them to close the ears as well so that they can feel the vibrations. But that's only initially to facilitate the resonant voice, forward focus. And there are several approaches developed in this area, something called LMRVT, Lissac-Madsen resonant voice therapy, Y-buzz therapy, straw phonation, SOVT exercises, semi-occluded vocal tract exercises. Several of them has been developed, but the principle is same. You need to create the forward focus, right? So I think you're running short of time as well, but this is pretty much clear. You bend forward and make them feel the vibrations. Once you do that, you can feel the vibrations, the tingling sensations in the lips, teeth, something like versus.
Sir, it's okay. You can take another 5-10 minutes also. It's okay.
Yeah. I will be taking 5-10 minutes. Yeah, I'll take another 10 minutes and try to wind it up. Okay. Right. So it is like the backward focus versus where you feel the tingling sensation in the lips, teeth. Once you could establish that, ask them to phonate. Like, mostly what happens is when they come with the ah, they're not producing the resonant voice initially. So the transition has to be slow and gradual. Something like 1, 2, 3. So ask them to count numbers, speak sentences, like structured sentences. Then the answering questions. So slowly you can move on to. You can also use nonsense syllables like me, 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 me. But just see to that it's not nasalized. Our idea is not to nasalize. It's only to develop the forward focus. We are using forward sounds like Y buzz is like like in you. In that, take the Y portion over there, like again, that's a forward sound, anterior sound. So that promotes the forward focus. Okay. And another principle that voice therapy works on is a relaxed larynx produce optimum voice. Imagine, I want to give this example here about the tympanic membrane, because most of you have done impedance audiometry, right? And how the tympanic membrane works. When the pressure on either side of the tympanic membrane is equal, the tympanic membrane works at its optimum, right? When there's low pressure in the middle ear, it doesn't work properly. When there's high pressure, it doesn't work properly. It will be stretched or bulged, right? So similar way, in the larynx also, it has to be free. It shouldn't be pulled up or pulled down. As I just demonstrated for pubophonia, they go like, ah, my name is Gopi. So they're actually pulling the larynx up. So it is constantly stretched. The extrinsic laryngeal muscles are stretched. The intrinsic laryngeal muscles are stretched. So that's why they're having kind of muscle tension dysphonia, right? So when you relax the larynx, the voice can improve. The larynx has to be free from the tensions. When can the larynx be free from tensions? When you have optimal respiratory support. Something like when you have optimal financial backup, you can take any steps forward, right? You can start a new business with confidence, so that thinking that you have a backup. So similar way, the larynx can work at its optimum when you have optimum breath support, optimum mouth opening, right? So, but then when the patient comes to you, most of the patients, when they come to you, even vocal fold paralysis, when they come to you, they already has developed some hyperfunction, because they have to speak. They never stop talking. They've been talking. So they tend to produce a lot of effort to produce something like, my name is Gopi Kishore. So when they say that, the voice, the ventricular folds are coming to contraction. So they're actually tensing the muscles. And also when you have temporary conditions like pharyngitis, you tend to speak. Instead of giving vocal rest, you tend to speak like this. So eventually the pharyngitis reduces, but your voice becomes habitual. So habitually it became a muscle tension dysphonia, right? So relaxing the larynx would benefit the production of better voice. So how do you relax the voice? You can go for progressive relaxation, like slowly tensing the muscles and relaxing the muscles. So let them feel what is tension, what is relaxation. Like let them tense the muscles, like, okay, tense deliberately and relax deliberately, right? Visualization, you can let them see in the mirror, like giving biofeedback, visual feedback, or we have electromyography. So put an electrode on the sternocleidomastoid muscles and let them see how the muscle activity is on the screen, if you have that. If not, let them feel with the fingertips, they can feel the muscle activity. Okay. And deep breathing, manual therapies. I want to highlight a little on manual therapy here. The laryngeal manual therapy is massaging the laryngeal area. So this is given by Matheson in 2009, Matheson et al. So I use it for my thesis work as well. It's very effective. Just use it for 10 minutes. The person feels relaxed in their voice, and you feel immediate change in the voice quality and relaxation. So there are several steps in it. Like you need to feel the sternocleidomastoid muscle. So when you turn to one side, you feel the muscle. So put your fingertips on it, the pads of the fingers, and other side, like, like this, and give the support from backside. With the thumb, you give the support from backside, and then go massaging slowly from one end of the sternocleidomastoid. So this is the sternocleidomastoid, for your information, from sternum to the mastoid. So sternocleidomastoid muscle. So that's the first step in this. You massage the larynx. And second step is supralaryngeal muscles here. The omohyoid, mylohyoid. So these muscles will be pulling the larynx forward. So use this your palm to support the patient's chin, and stretch the muscle, the supralaryngeal muscles gently. Right? I know it requires demonstration. You can refer to the article Efficacy of Eclectic Voice Therapy, Laryngeal Manual Therapy by Matheson. I have the article. I can forward it to you guys if you're interested. So that has given step by step behind the article. So they explain how to evaluate, how to do the steps. In fact, these pictures are from the article. Okay. So second step is kneading the laryngeal muscles, like how you knead your atta for making chapatis or rotis, right? So you have to knead the laryngeal muscles, supralaryngeal muscles. And the third step is gently pull like how you do digital manipulation for pubophonia. So once you do the first two steps, when the larynx is relaxed, you can pull down gently so that the larynx will feel totally relaxed, and the gap between the thyroid and hyoid increases. Okay. But there is a caution here. You have to be very thorough with the anatomy. Should be able to feel the thyroid, the prominent hair. Should be able to feel the hyoid. Just go like this. And the first bone that you feel is the hyoid here. Should be able to feel the thyrohyoid gap. Right? So once you're thorough with that, once you do it on yourself, once you try to palpate your friends, family members, then you can use it on your patients as well. Okay. And the last principle is optimizing each subsystem would give you a better holistic outcome. So work on each system, work on respiration, use effective breathing pattern, like abdominal pattern of breathing, work on forward focus, like using resonant voice therapy or any of the approaches that we discussed. Work on relaxation using LMT, like laryngeal manual therapy that I show in the pictures, or using progressive relaxation. And practice phonation and speaking tasks using all these subsystems at their optimum level. So that's what we call as eclectic voice therapy program, that is combination. Okay. So when you combine all these, that will improve the voice. So that's all about the voice therapy approaches I have. So I made some principles and how to plan the session. I'll just say one or two sentences on this. Like you can plan the session, like initially I already mentioned about, start with vocal hygiene education, show them the videos of their voice and normal voice. And starting of the session, always take a feedback, how they worked at home, what are their experiences over the week that you haven't seen them. And then review and listen to their voice, maximum phonation time, that'll give you an idea. And then start with your breathing exercises, then start with the resonance exercises, then if required, the laryngeal massaging and laryngeal manual therapy. And trust me, it is not that you told the patient on first session and the therapy is over. The patient needs time to master the technique. Imagine you need years of experience to master the technique. Like you have to do it several times to understand how it is feeling. The patient also has to, because the patient doesn't even know the anatomy, physiology of voice and what's happening with him. So every session you work the same things, but you will be tracking the progress and you'll be giving constant feedback to the patient. Okay, this is good. Your resonance is good. You have to still work on the breathing. So constantly giving feedback, and every session you're trying to improvise and giving constant feedback and try to help him master the technique. Okay. And how to track the progress. I'll tell you, don't go for any hi-fi devices like MDVP or CSL. You not go for simple maximum phonation time. Don't use it as an exercise, but then you can see the maximum phonation time. The person is able to produce, the person is producing relaxed voice, not tensing and producing for 15 seconds. But imagine the person comes to you with 3 seconds of MPD. Okay. And after 2 sessions, it goes to 5 seconds. That is an improvement. After 10 sessions, it goes to 15 seconds. That is an improvement. So tell the patient, okay, now your voice, the MPD is 3 seconds. When it comes to 15 seconds, you'll be discharged from therapy. Now the patient knows when he'll be done with therapy. He'll not bother you, sir, how many more sessions? Because he can produce and see the timer. Sir, it is 5 seconds. I have seen my patient saying that, sir, I came up to 5 seconds. I have to do 10 more seconds, right? So that's how you can track the progress and make your patient more responsible in handling the voice therapy. Okay. And when you work as a team, you, the ENT and the patient is also a team member. When you work as a team, you will see the best results. Okay, so that's all from my end. Hope that will give you an idea about how to work with a patient when it comes to your clinic. So I'm ready to answer any questions that you have.
Thank you, sir. Now we can take up some questions. So participants, we have some questions in the chat box. If anybody else has a question, can put up in the chat box. We have a question from
yes, go ahead, please.
Dr. Satish. What is the best vocal hygiene and best diet with GERD patients?
Vocal paresis.
GRD patients, right? See, basically, gastroesophageal reflux disorder. When a person has gastroesophageal reflux disorder, the stomach can withhold all our digestive juices, gastric juices. But when it comes to the esophagus, it cannot. That's not meant to use, those juices. So when it comes over there, constantly you have regurgitation. I'll stop sharing my screen otherwise. Yeah. When you constantly have that regurgitation, the esophagus is inflamed now. You have constant gas production, right? So that's why the person tend to get burps, burning sensation. And slowly when it comes to the laryngeal level, that's when you feel redness, all this, right? And the voice changes eventually. So initially the person will have burning sensation, gastritis, then the esophagitis, then comes the LPR, the GERD, and the voice changes because of the GERD. So now coming to the diet, anything that's triggering the acidity, some people tend to develop more digestive juices, acidic, the acidity, the acids generate more in them. So they are given with the anti-acid medicines. So the ENT could prescribe some medicines for them. So if they take it for at least 10, 15 days or the course, whatever it is, so the excessive production of the digestive juices can be controlled, right? But then coming to the diet, anything that's triggering the refluxitis, the hyperacidity should be avoided. Something like mint, the spices should be avoided, or any other thing. Each person will be different. If they saw that something is triggering their acidity, they better avoid that. But it is not only the diet control. Sometimes it is, some people are prone to develop acidity. Some people, they even sleep at 2 o'clock in the night, eat well and sleep, still there is no acidic issues, right? So it depends on the person to person.
Thank you so much, sir. So we have one more question. What are some voice therapy techniques that we can use for spasmodic dysphonia?
Okay. Well, spasmodic dysphonia is also called as vocal stuttering. And so this is where you will see involuntary spasms when a person produces voice. So instead of a rhythmic vibration of the vocal folds, now the muscles, the intrinsic muscles of the vocal folds, like all these like cricothyroid, thyroidnoid, lateral cricoarytenoid muscles, all these are going into spasms, right? So for the excessive spasms, if they are there, one way is going for Botox to reduce the spasms. But from the voice therapy point of view, you can go with easy onset of phonation, because the spasms are real. It's not a behavioral problem. It's a neurological problem. So unless like a person with vocal nodules or muscle tension dysphonia, you are treating and the problem is gone. Spasmodic dysphonia is not like that. It is a neurological problem, right? And at some point of time, people used to think it as a psychogenic condition as well. But there is literature, established literature, saying that there are some changes in the brain that leads to the spasmodic dysphonia, right? So it's a neurological condition. For therapy, there is no direct therapy very well documented for spasmodic dysphonias, but you can work on any of these approaches that we discussed till now. You can work with vocal function exercises. You can work with resonant voice therapy and easy onset of phonation. So I would usually go with like release a breath a little, then phonate. Something like instead of saying it as that's how the voice will be. Just go with my name is, like, kind of little breathy voice. If it is adductor spasmodic dysphonia, can start with that. And moreover, it is not always the larynx that gives you the benefit. That's what I talked to you in the starting. It is the coordination across all the subsystems that improve the voice. I had a patient with spasmodic dysphonia, severe spasmodic dysphonia. He actually had a syndrome where there's something called blepharospasms. Like he had contractions in the lips and the eyelids it's called Meiggs syndrome, I believe. Meiggs syndrome. Yeah, they have spasms in multiple muscles of the body. They have spasms in the eyelids, so he cannot see. When he sees somebody, the eyes will go like this, and the lips will go to spasm. The larynx will go to spasm. So now for this person, he was taking Botox for eyes, was taking Botox for lips, because he cannot see. He was taking Botox, but he was not at all ready to take Botox for the vocal folds. So the neurologist referred him to me, like to Aish. So I know the patient would not benefit much with easy onset or relaxation. Believe me, the muscle tension dysphonia approaches like relaxation or laryngeal manual therapy does not work with them, because the problem is not in the muscle. The problem is in the neural inputs, right? So what I did, I worked on the respiratory system. I helped him improving the breath support. I helped him improving the resonance. I helped him improving the articulation, like wide opening of mouth and clear articulation. So the patient was so happy. I was thinking the patient did not improve, but he wrote a letter to me. He's a 70-year-old from Bangalore. He wrote a letter to me saying that, Dr. Gopi, you are so helpful to my voice, helpful to me. It's because you have to see what is the best we can do given the residual capacities, right? So when the respiratory system goes to its optimum level, resonance goes to optimum level, articulation goes to optimum level, when they are working at their best, even the larynx is not working properly, there will be some compensation. Does it make sense? Right? So we are not directly working on the laryngeal muscles as such, but we're working on all subsystems that would compensate to some extent.
Thank you, sir. We have one more question, sir. What are the treatment options for vocal fold paresis, especially those who have glomus jugular tumor, who have undergone glomus jugular tumor surgery?
Okay, glomus jugular. I haven't come across this patient, honestly. I haven't seen them, but when you see glomus jugular, that's at the level of middle ear. That's what I studied in my bachelor's, I remember. So glomus jugular, oh, am I right? It's the artery that goes under the middle ear, right?
Yes, sir.
Right,
yes, sir.
right. So see, sometimes definitely you have to look at the signs and understand clearly what's happening with in the glomus jugulaire. Sometimes the patient comes to you, I had a what is that, open heart surgery. Somebody had open heart surgery and they come to you within a week with vocal fold paresis or hoarseness. So now we have another condition you're telling about, glomus jugulaire surgery. So as a speech pathologist, you definitely have to look through all the reports, but try to understand why there is a voice problem. The surgery is done to the somewhere under the ear, but why is the voice affected? It could be possible. There are two reasons here possible. One is when the person undergoes a surgery, there will be inflammation. The muscles will be swollen. Something like you hurt somewhere. There'll be you cut somewhere. They'll be swollen initially, right? The muscles near to that will be swollen. So same inflammation happens after the surgery. Let it be a cardiothoracic surgery, like open heart surgery or something, or the jugular surgery, whatever the surgery is done. Because of this inflammation, there'll be pressure or compression on the vagus nerve. So the nerve is now compressed constantly. So when the nerve is compressed, there will be vocal fold paresis. It need not be total paralysis. The paralysis happens when there is a total damage to the nerve. The nerve is like severed, cut. That happens, vocal fold paralysis. But paresis is like partial paralysis, where a slight change in voice. So this could be because of the inflammation, the swelling. So the swelling would go eventually with time, right? So you can still work on the voice, the vocal function exercise that I mentioned. The swelling would go off. So if the person is improving very quickly, it could be because of voice therapy, but also it is because the person is recovering from the inflammation now. The other possibility is the nerve is cut. So the nerve anastomosis takes place. The nerve endings still join eventually, but then your voice therapy has to follow, continue for a longer duration rather than for 2-3 weeks. In case of inflammation, now it has to go for longer duration. So to summarize, I think you should see from voice pathologist perspective how the voice is affected rather than what surgery is done. You should know about surgery, but what happened to the voice, what happened to the vocal folds. So that's of more importance to you. So I mean to say symptomatically, what happened to voice.
Thank you so much, sir. Is it okay for you, sir, to answer 2 to 3 questions more, sir?
Yes, I can.
Or shall we take it up later, sir? Is it okay for you?
I mean, it's something like you can answer later. That's fine. If anything unique, I can take up another 2 questions. I'm always happy to speak to our students, students and colleagues.
Yeah,
Or
okay.
Hyderabad. I think people from all over India are attending it, right? Because that's the advantage of online system, webinars. Yeah, I can take up 2 more questions.
Yes, sir. How much of voice rest is recommended for professional voice users, sir?
That's a very good question. Voice rest is contraindicated. Never give voice rest. If you're giving voice rest, you're actually, not benefiting the patient. In fact, you're hurting the patient. Imagine somebody has a broken hand, right? Hand is broken. They put them on plaster of Paris. There's a fracture. So after being there for 2 months or 1 month, can he able to move the hand easily? And can he go for bowling? Can he go play cricket? He can't even able to move hand easily because there'll be a lot of stiffness, right? When the muzzle is not used for longer duration, there'll be stiffness in the vocal fold, stiffness in the muzzle. Same thing happens to the vocal folds as well. When the vocal folds are not used for longer time, there'll be stiffness in the vocal folds, or there can be atrophy in the vocal folds. As I mentioned, in vocal fold paralysis, the atrophy takes place. So you can have something like disuse atrophy. You're not using, so it's something like your electronic gadgets. So it happens like that. So, but yes, the vocal rest is recommended only after surgery to vocal folds. when there's a vocal polyp that is removed, vocal cyst that is removed. So it is recommended for 3 days. That's the maximum vocal rest after surgery. The patient did not undergo surgery, no vocal rest at all. Let them use it, but in a better way. Not to use unhealthy practices. Instead of using yelling, now ask them to speak in a relaxed voice. Ask them to take naps in between. So as I told you, like take a gap after 15 minutes, take a gap after 45 minutes. When they feel vocally tired, take a gap. But don't take a continuous voice rest. That's not going to benefit.
Thank you so much, sir. Can you please explain why buzz, sir, and the rationale, the physiology behind it, sir, once again?
What is that?
Why buzz, sir? In SOVT exercise.
Oh, why buzz?
Yes.
Why buzz is actually, see, that's why I didn't focus on specific therapy approaches. Why buzz, or you say humming, or you say straw phonation, semi-occluded vocal tract, all these are done only to facilitate a forward focus. So when you say forward focus, you have to take a phoneme which is forward, right? Why are you taking humming? Because that's a forward phoneme, like this. So when you do Y buzz, Y is also a forward sound. So when you say so you're actually touching your palate, alveolar ridge, and you're buzzing over there. So ultimately, any activity you do, you are facilitating forward focus. That's the gist of it.
Thank you so much, sir.
You're welcome. All right. So I'd like to thank Khan sir for giving me this opportunity, and our HOD SLP, Miss Susan, and all my students and teachers and my clients who helped me, develop interest in voice, all my teachers from AYJSRC and Aish, all my patients, students. Thank you so much, everybody.